All right. So Brian asked me to talk about some infectious disease issues in orthopedics. So we'll kind of go over a couple of different things: some antibiotics, some basics, some overviews, some uh, case studies, and we'll make it a little interactive. So, what are antibiotics? Antibiotics are medications to treat bacterial infections. So, obviously you guys already know this. Ideally, before antibiotics are given, you should try to get a culture from the site to make sure that the cultures are not altered. Antibiotics generally are classified as two types: bactericidal versus bacteriostatic. Um, Now, unfortunately, I'm sure you guys have all kind of felt this in some capacity. So, anytime you get a deep infection after arthroplasty, it's a huge deal, right? So, big deal for the patient. Um, from a mental standpoint, from a physical standpoint, all these patients, they come in because they have pain in their joints and stuff, so they're trying to look for some improvement. So they're get these joints put in, and they're feeling well, and then they get infected, and then it's just a big psychological depressive event for them. Um, Prolonged management, multiple surgeries, significant medical costs, and uh, we've kind of realized that even though there's been a lot of advancements in medicine in terms of what we do from the infection standpoint, not much has changed to alter these infections. So we get cultures, and cultures, you get the gram stain comes back. So the microbiologist will look at it under the microscope, and they'll report out, uh, gram positive cocci or gram negative rods or gram positive rods. So that's important for us because that kind of gives us obviously an idea of what organism this might be and how to treat these individuals. So we'll kind of change base a little bit. So 66-year-old female, 7 years after total hip replacement, complains of hip pain for the last 4 weeks. She's had history of multiple urinary tract infections for the last 2 months. No fevers or chills. Has some pain with the right hip range of motion. Her white count is okay, but obviously her ESR and CRP are a little bit elevated. So, what in this kind of situation, what organism would you think would be the prevalent organism? Yeah, so exactly. So this patient, has urinary tract infections. Obviously, urinary tract infections for the most part are gram negatives. So probably what happened is she probably had some hematogenous spread and seeding. So she had a hip aspiration. The gram stain was negative. So gram stains are somewhat unreliable. If they're negative, that doesn't really mean too much. If they're positive, that gives you added information up front. And her culture was positive for Klebsiella. So these are all the various classes of antibiotics. Obviously, we're not going to go through all these, but we'll go through some of these. So this is what a gram-positive organism looks like. So this is kind of going back to microbiology. So you have your cell membrane, cell wall, and penicillin binding protein. And then this is a gram-negative bacteria. So it's a little bit different. It has an outer membrane. It has this uh, periplasmic space. It has porin channels, so a little bit more of a complex organism. And then, depending on the antibiotic that you utilize, this is where these medications work on the organism. So this is a nice box that kind of I kind of keep mentally in my head. So you have gram positives, you have gram negatives, you have anaerobes. So these are all obviously the organisms that you want to cover. And then you have some kind of special ones. So you have highly resistant gram positives, you have highly resistant anaerobes, and you have highly resistant gram negatives. So you'll kind of see how this slide works in a couple of minutes. So um, a 60-year-old female presents with 2 days of purulent wound drainage for 2.5 weeks. She's afebrile. ESR and CRP are elevated. What's the next step? Yeah, so I guess aspirate, and probably eventually needs to go to the OR. She gets debrided. Her cultures are positive for MSSA. Gets a PICC line. Gets discharged on IV therapy. Usually about 6 weeks of IV therapy, then followed by 3 months of oral therapy. So beta-lactams. So beta-lactams are penicillins, cephalosporins, monobactams, which is aztreonam, and carbapenem. So we'll touch a little bit on those. So what's the mechanism of action for beta-lactams? How do they work? So the way that they work is that they kind of bind to this penicillin binding protein, and then as a result, it causes disruption in the cell wall, and then the cell wall breaks, and then the organism basically dies. So if you remember that kind of triangle before, so ceftriaxone is a third generation cephalosporin, so has coverage for gram-positive organisms, has pretty decent gram-negative coverage, but you see that the gram-negative coverage is not as good as the gram-positive because it doesn't have any pseudomonal coverage. It doesn't have anaerobic coverage, so that's why that's black. And it doesn't have coverage for resistant pathogens, so stuff like MRSA and VRE, is not covered. Also, cephalosporin, you see there's a big hole for Enterococcus. So all cephalosporins have no coverage against Enterococcus. So Zosyn or piperacillin tazobactam, so that's a drug that we use pretty frequently. So you can kind of see how this has a little bit more coverage for gram-positives, has more coverage for gram-negatives, has great anaerobic coverage, but once again, somewhat lacking in highly resistant gram-positive organisms and highly resistant gram-negative organisms. Cefepime, same thing, doesn't really have anaerobic coverage, has great gram-negative coverage, great gram-positive coverage, once again because of cephalosporin, no coverage for Enterococcus, and it doesn't have coverage for these highly resistant pathogens. So aztreonam or Zactam, so this is a pure gram-negative drug. So typically we utilize this drug in individuals that have penicillin allergy because it's a monobactam, so it doesn't really have the same risk of cross-reactivity that cephalosporins or penicillin do in regards to the allergy. Carbapenem, so imipenem, meropenem, and ertapenem. So what's the major difference between imipenem and ertapenem? Imipenem has better gram-negative coverage, imipenem has better anaerobic coverage, or ertapenem has better gram-positive. So the difference is that imipenem and meropenem have pseudomonal coverage, whereas ertapenem does not. So it has a extra component of gram-negative coverage. So this is ertapenem, this is imipenem. So you can kind of keep this kind of triangle in your head, and you kind of see that the way that we kind of approach this is that if a patient is on an antibiotic and then they continue to have infection, not so much for infections that source control is required, but let's say, for instance, a patient has a urinary tract infection, so they're on, Zosyn, for instance, and now their blood cultures are positive or their urine culture is positive. So then you say, okay, well, why is this patient still having positive cultures on an antibiotic? So where's that hole in coverage? So Vanco, obviously, this is a pretty big staple of what we use. So what's the mechanism, or where does it attack the cell wall? Or I just gave away the answer. So it works on the cell wall synthesis. So there's this component called diala. It's in the cell wall, and basically what vancomycin does is that it ligases that, so it doesn't allow the cell wall to form. So Vanco obviously is a pure gram-positive agent, and any organism that has resistance, so VRE, or sometimes you'll see in the cultures they'll say high MIC for vancomycin, so those are a little bit more resistant, and Vanco may not be the best agent for those patients. So daptomycin, so this is a drug that you have probably seen us use in the past. So which of the following is true regarding daptomycin? It's a bacterial cell wall inhibitor, CPK should be monitored. It causes renal failure in 4 to 7% of patients. So one of the things that dapto, it can actually cause rhabdo. So typically, what we need to do is we need to monitor CPKs while the patient's on it. So we like to use dapto a lot, particularly in the outpatient setting because it's um, it's just a very clean and easy drug. When you use Vanco, Vanco is very good in the hospital because in terms of dosing, the duration that the drug needs to be infused, it usually gets infused over an hour and a half. Getting trough levels at random times, at night or in the morning is not a big deal when the patient's in the hospital and someone is able to do that. But in the outpatient setting, to send a nurse to someone's house, exactly at 2:30 because they're getting their dose at 3, can be somewhat challenging. Getting the results of the Vanco and making appropriate adjustments, having the patient be on Vanco for an hour and a half, 2 times a day is a little bit cumbersome for the patient. Dapto is nice in the sense that, it's once a day, no need for monitoring levels. The infusion is about 30 minutes. So it's just a much more user-friendly drug, particularly in the outpatient setting. So the way that it works is it works on the cell membrane. So Dapto also is a pure gram-positive drug, but unlike Vanco, it does have some added coverage for VRE and those somewhat resistant Staph aureus to Vanco. So this is just some other information that we talked about.
Is that a once a day drug?
Once a day, yeah. Yeah, so it's really nice because and the infusion is 30 minutes. There's actually even some data that talks about a 5-minute push. So it's nice. You wake up in the morning, you take your drug with your coffee, and you're off and ready to go.
You can monitor the CPK basis.
Yeah, I mean, typically it's pretty rare to get elevations in the CPK, but usually we monitor it on a weekly basis. And then what happens is that if the CPK starts rising, so a lot of patients will get asymptomatic rises of their CPK. So their CPK will be, say 600, then you'll call them up and you say, how you feeling? They're like, I feel fine. So we don't really do too much for those except just watch them closely. Sometimes they'll, get higher, and then they'll start saying, I'm getting some muscle aches and some pains and stuff like that. And then typically what we do is we just lower the dose a little bit, and that tends to alleviate that issue. So linezolid. So Dr. Lee told me to ask this because he said he had a conversation with someone about linezolid this week. So which of the following is true regarding linezolid? The oral bioavailability of linezolid is excellent. About 40% of MRSA are now resistant to linezolid. Thrombocytopenia is the most common lab abnormality, or it works by disrupting bacterial cell wall synthesis. So this one's actually, there's two answers. So number one, the oral bioavailability of linezolid is excellent. So it's a drug that you really, unless the patient can take orals, that would be the only reason that you should use IV therapy. And one of the things that needs to be monitored is that it can cause thrombocytopenia. Usually the thrombocytopenia is going to be somewhere in the range of, if it's going to happen, 10 to 14 days. So if you put a patient on linezolid on day number 2, their platelets start dropping, it's probably not from linezolid. But let's say 2 weeks later, all of a sudden their platelets are 80, then you have to kind of look at it. And once the patient gets off the drug, that thrombocytopenia resolves. So this works on the in terms of ribosomes, in terms of how it kills the organism. Also, very similar coverage to daptomycin, so a gram-positive only drug. So a 62-year-old female is started on linezolid for MRSA vertebral osteo. Her medications include Coumadin, atorvastatin, and citalopram. 2 days later, the patient presents with confusion and fever exam shows a diaphoretic and confused patient with uh, a fever, a high pulse, and blood pressure of 160 over 110. She has dilated pupils, hyperactive bowel tones, hyperreflexia in the lower extremities. What is the likely cause of this patient's symptom? So one of the big things that occurs with linazolid, and this is black box warning, so you have to watch out for this. This occurs in maybe about 1% of patients. Is that you can get this phenomenon which is called serotonin syndrome. So that's basically this kind of example. So it's kind of the patient will have flushing, they'll have anxiety, they'll have dilated pupils. Um, and that's because she was also on citalopram. Now the problem is that um, unlike other drugs, a lot of these antipsychotics, antidepressants, even if you stop the drug stays in the system for multiple weeks. So it's not as if you can tell this lady, oh, we'll just stop your drug and then we'll put you on it because the drug will still be in her system. So we still use it in these patients, but you just need to warn the patient that if any of these kind of side effects start occurring, then obviously inform someone. And if there's suitable alternatives, then you can use those instead. All right. So a 26-year-old thrill seeker suffered an open fracture of his right tibia and fibia while rollerblading behind a motorcycle driven by his ex-girlfriend. The fracture was reduced and fixed with the placement of screws, plates, and rods. He did remarkably well until 4 months later when he noted a pimple followed by a little drainage from one of the wounds. 4 days later, he was chasing his ex-girlfriend up some stairs and he heard a loud crack and looked down to find hardware and bone protruding through his right leg. What is the most likely organism? Yeah. So Staph aureus and coagulase negative staph are obviously going to be the more likely pathogens. Gram negative seems less likely. What specimens do you want to send to the lab? So bone cultures. Can you rely on cultures taken from the sinus tract? So this is a big take home point. So the answer is generally no. So sinus tracts are when you take cultures from them are generally unreliable unless Staph aureus is isolated or there's a single organism. But if you kind of swap the sinus tract and you get 4 or 5 different pathogens, it's really unclear which of those pathogens is really the organisms that is causing issues and which of those have just kind of colonized that area, unless it's Staph aureus or you just get one organism isolated. So fluoroquinolones.
Can we go back to that just for a minute, just in terms of bone cultures versus like tissue cultures? Is there a difference that you find?
Uh, there is some degree of difference. I think some of it is that if you know that the bone culture, so if you get a pure specimen and the bone culture is negative and the tissue culture is negative, so the bone culture is negative and the tissue culture is positive, um, you may not treat that patient as aggressively as if you would be treating that patient with as an osteo.
Right.
Whereas if the bone culture is positive, obviously, then you have true confirmation that that is osteo, and then you have to kind of treat it as such. And it's also more important just kind of for follow up and potential relapse, because if the bone is intact and the bone is not infected and it's just the tissue, then that person's chance of cure is higher. If the bone is infected, then obviously, yeah.
How much do you rely on just because they always tell us, you culture what you biopsy and you biopsy what you culture back and forth. So are you looking to make the diagnosis either way, either with a positive culture on the bone or with just the analysis?
So I think actually both of them are helpful because a lack of a positive culture does not correlate with lack of infection.
Yeah.
Right. So if you get a bone culture and the bone culture comes back and says, there's active inflammation, signs and findings are suggestive of osteo. But now let's say the organism doesn't grow for whatever reason. Maybe the patient was on antibiotics,
Right.
or maybe it's just not a highly virulent organism, so it doesn't grow. But if you have pathology that says that this patient has osteo, then you still kind of treat it as osteo. If you have the bone culture that says that, this is the organism that grew. So let's say if the organism came out to be, say, Klebsiella, right? So then you say, okay, well, I would target Klebsiella and use an agent that has that. Whereas if it's only the pathology is positive and the culture is negative, you're not sure. So now you're like, okay, well, I have to cover, gram negatives. I also have to cover gram positives. You add, a broader range of coverage, which if the culture is positive, then you don't necessarily need to do that. You can have targeted approach and stuff. And I think that from our standpoint, and, obviously from your standpoint as well, you don't know what those cultures and that path is going to show, when you're in there. So from our standpoint, it's always better to just have all that information up front, because it's not as if then we can say, hey, can you go back and get another culture so we can see the path, because we didn't have that information.
So you did both tissue and bone.
Yeah.
Culture. Yeah. And the tissue, you actually take a piece, just swab it, right? Or you do a swab instead.
Usually we'll try to take a piece.
Yeah. Do you find more likely?
Which I get something to go over.
Yeah. Do you find more likely that the tissue hits as opposed to the bone, or just depends?
It depends.
Yeah.
If they got antibiotics.
Yeah. I mean, I would say when I've just kind of anecdotally looked at this, I think tissue cultures tend to grow better than bone cultures.
Right.
You know, I think that the information that you get is still valuable from both, but I just think that the yield of bone cultures in general is less. Like bone cultures don't seem to grow as well as tissue cultures. But then at the same time, if you have multiple tissue cultures, like if you have a scenario where, let's say, the bone culture is negative, the path is positive, and the tissue culture shows this organism, you can almost kind of correlate that that's the organism that is causing the osteo. So it's still helpful. So fluoroquinolones, so they work on the DNA topoisomerase. Um, there's a couple of different ones. So levofloxacin and moxifloxacin are good antimicrobials for skin and soft tissue infections. Cipro, not as good, but usually use it for urinary tract infections. They have excellent bioavailability, so really oral therapy is okay. So one part that I kind of left out, which is extremely important. So quinolones have a black box warning, right? For what? Then yeah. So and no one is really even sure in regards to the tendon rupture component. Um, how long? So is it when the patient is just on the fluoroquinolone? Is it when the patient, does that effect still exist when the patient comes off the medicine? How long it goes? There are some case reports that even up to a year, patients have had tendon rupture after being on fluoroquinolones and stuff. So obviously, in your patient population, if this drug is used, I would make sure that you mention that. So a 39-year-old intravenous drug user presents to the ER with fever and back pain. He mixes his drugs with dirty tap water and does not prep his skin before injecting. This sounds like a typical patient we see. On exam, his temperature is at 39 degrees and he has a 3 out of 6 hollow systolic murmur and tenderness over his thoracic spine on percussion. His neurologic exam is initially normal. So what's the diagnosis?
All right.
So endocarditis, definitely. Any other? Yeah. So endocarditis, vertebral osteo, epidural abscess. So those are all kind of in consideration. Likely organism. So Pseudomonas definitely is something that you would have to consider because of why the water, yeah. But the most likely organisms in these kind of situations is still staph. So initially, so what type of antibiotic would you put this guy on? So I think Zosyn's not unreasonable, but so what you want to do is so these are the organisms that you're worried about, right? So Staph aureus, strep, and gram negative. So you mentioned Pseudomonas, so you definitely want to put them on some agent that has anti-Pseudomonal coverage. So Zosyn would be acceptable, but at the same time, if you kind of remember a few slides ago when we looked at that kind of triangle of what Zosyn covers, it doesn't have great coverage for highly resistant gram positives, right? So we know that Staph aureus is a bug that we would be concerned about. So we would definitely want some sort of MRSA coverage. So whether that's Vanco or Dapto, but some gram positive coverage that includes MRSA and anti-pseudomonal coverage. What sort of imaging studies? Yeah, it's like you had a copy of the slides. So the lab reports that 3 out of 4 blood cultures have turned positive in 4 hours and are growing gram-positive cocci. And the following day, the lab reports that 2 blood cultures are growing gram-negative rods. So we already kind of talked about this. So Staph aureus, strep, Pseudomonas are the bugs that we would be suspecting. So now the patient starts complaining of mid-thoracic radicular pain. What does this represent? All right, so this spinal ache, so first sign of spinal abscess. So, in our when we see these patients, if the echo is normal and they're still persistently positive, we always look in the back. The back is a very hotspot for seeding of these organisms. So this, so I don't know what you guys know about slime or biofilm or the glycocalyx. So this is, so there are certain bacteria. What they basically do, and this is more for when there's a prosthesis involved. So they basically make this kind of slime layer or this glycocalyx, and we'll kind of go into that. So what happens is you get a single or multiple species, and then it basically kind of forms this kind of slime layer over it. And what happens is that makes it difficult for the antibiotic. So this is kind of your prosthesis, and these are the bacteria, and it kind of forms this kind of slime layer over it. So what happens is that when you use your drugs, antibiotics, it has a very difficult it has a lot of difficult in terms of penetrating into the source of the infection. So it basically kind of attaches, and then it kind of, forms this layer, and then it just kind of grows. And that's why a lot of these patients, what happens when they have a prosthesis, whether it's, pacemaker, heart valve, artificial knee, they'll go on antibiotics, they'll, get better, and then they'll come off antibiotics, and then 4 or 5 weeks later they basically relapse. So usually Staph aureus, coagulase negative, staphylococci, those are the main ones that are responsible for forming the glycocalyx. So rifampin is a drug that we utilize. So what rifampin has the capacity to do, it's almost kind of like a scrub. It basically kind of scrubs that biofilm down, and then what it does is that it allows these other drugs, so whether the patient's on Ansep or Dapto or Vanco or whatever, allows those agents to kind of come in. So when you'll see the susceptibilities, they'll say rifampin susceptible or rifampin resistant. You should never use rifampin alone because when you use alone, very high chance of developing resistance to rifampin. So rifampin alone is not really that good, but when you use it in conjunction with other agents, very effective. Now the problem is that number one, it has a small degree of liver toxicity. We when these patients are on antibiotics, we obviously are watching their labs on a regular basis, so we kind of monitor for that. You do have to tell them that all their body secretions are going to turn orangish and stuff. So I had exposure to meningitis at one point, so I took rifampin, and it's really like pretty wild. Like when you pee, it just comes out like Tang, just very bright orange and stuff. And if you don't tell them, then what ends up happening is at 2 o'clock in the morning you get some panic phone call. Like I even had a patient who came with like a jar of his urine, and he's like, "This is so you have to make sure." So like after that, like I tell every single patient that goes on rifampin that your urine is going to turn orange. Don't get alarmed. Um, the other thing is that has multiple interactions with drugs. So, birth control. So if females on birth control and they end up on rifampin, birth control is not going to work as well. So you want to let them know that. The other thing is that so sometimes you'll get phone calls from us based on if we want to use rifampin, because a lot of the agents that you guys use for anticoagulation, they don't work well with rifampin. So Pradaxa and Xarelto, all those new drugs, they're all very ineffective when the patient's on rifampin. Even Coumadin, Coumadin, when patients on rifampin, it's going to throw their Coumadin levels up. Now the difference is that at least you can kind of adjust the dose of Coumadin to get an INR that's appropriate, as opposed to those other drugs that are going to be subtherapeutic. So, a 23-year-old female reports to the emergency room with 2 days of diffuse arthralgias, low-grade fever, and then the development of swelling and increased pain in her right knee and wrist. She has a new boyfriend. So, what's her diagnosis? Gonorrhea, yeah. So, what do you find on exam? You can get skin lesions occasionally, tenosynovitis, but one of the things is that you get this, not multiple, but a few joints that are involved. So in her case, she had right knee and wrist. So will the blood culture grow the organism? If you aspirate, will the joint fluid grow it, or will the cervical culture give you the highest yield? So the blood cultures are relatively unreliable, less than 20%. Even joint fluid is not really that good. It's really cervical culture that would be helpful. And antibiotic therapy, so typically we use ceftriaxone for about 7 to 10 days. How about anyone else needs treatment? So obviously, yeah, her boyfriend needs to be treated.
Yeah. Weeks ago,
Oh, yeah?
we treated, and it was all, everything you said.
Uh,
Not personally. Yeah.
I mean, I think, yeah. I mean, that's really. I mean, if you make the diagnosis, right? You don't. The purpose of GYN in this situation would be that if you want to get if you want them to get a cervical culture to say that yes, this is it. But there are other tests that you can get that will show someone being positive for gonorrhea or chlamydia. So it's a urine nucleic acid amplification test. So that's pretty reliable. So if you have someone that has that test that's positive for gonorrhea, and then they have these kind of symptoms, you pretty much kind of put the two and two together and say that's what this individual has. Huh? No, yeah, because I mean the joint fluid is only going to be positive about 50%, right? So, but if you have someone who's like, oh, I'm having, I have a new boyfriend, I don't really know his sexual history, I think he may be cheating on me. And then they come in with all these symptoms, and then their urine nat is positive. So I had a patient that it was a very awkward conversation because it was a patient that came in with Reiter syndrome, so arthritis, uveitis, and some urethritis, and he was married, and his wife came to the appointment with him, and he had his the person who sent him to me was a rheumatologist, so she had sent off a urine test for chlamydia, and it came back positive. And I was having this whole question with him, and this whole discussion, and he pretty much said that they both pretty much said that, oh well, we couldn't have, I don't cheat on my wife, and my wife doesn't have it, and the wife's like, I don't cheat on my husband. And I was like, well, you really don't get this any other way. So clearly one of you is, doing something that you probably shouldn't be doing and stuff. And I'm not here to play marriage counselor. I'm here to treat your chlamydia. So, uh, but yeah, so, both of them ended up getting treated, but it was a very awkward and uncomfortable conversation for everyone, myself included. All right, so this is kind of just surface. Obviously, we can't go over all the issues, but hopefully this gives you a good overview of kind of how we approach patients, and some of our thought process, and some of the stuff that goes on from IT standpoint, and how we choose antibiotics, and why we choose Dapto instead of Vanco, and why we choose Astranum instead of Zosyn, and so on and so forth. So kind of open it up to you guys. Any questions?
First of all, I thought that was excellent.
Thank you.
A lot of these terms I haven't heard in a while. Oral versus IV antibiotics, like when you decide to send someone out on Zosyn, let's say, I would imagine oral is cheaper and it's easier to handle.
Yeah.
But oral Zyvox versus IV Dapto, that sounds like those are kind of live in the similar areas.
Yeah. So the main issues with that is that one of the problems with oral Zyvox is that it's that risk of thrombocytopenia so depending on how long you're going to treat the individual for. So if you're treating, say, like a prosthetic joint infection, like, okay, I'm going to do 6 weeks, 8 weeks, something like that of therapy. It's just a matter of time before you start running into some issues. So, maybe you get 2 weeks, maybe you're lucky you get 3 weeks, maybe if you're lucky you get 4 weeks. And then, inevitably you kind of start seeing these platelets start going down. So then you're like, okay, well now I gotta, get off this drug, and now what do I go to? The other thing is that Zyvox is bacterial static, whereas Dapto is bactericidal. So sometimes for some of these infections, like say like an osteo and stuff, you would much rather have a bactericidal agent rather than a bacterial static drug.
So it sounds like Dapto is kind of your go-to for some of these gram-positive.
Yeah, I think that the ease of dosing, once a day, 30 minutes is much better than an hour and a half twice a day, in terms of safety. So there's no issues with levels, because you like if you see, like in the hospital, right? Like we start someone on Vanco and we check a Vanco level, maybe an hour later, we get that Vanco level back, and then we can make the appropriate intervention. So whether it's increase the dose or decrease the dose, right? Well, let's say if I have you on Vanco, right? So now the nurse comes to your house at 4:00, tonight. She gets a Vanco level. Now that doesn't get to the lab until, tomorrow morning. That gets run then tomorrow evening, we get the dose. Now we're already out of the office. So we see that result now on Friday, and we're like, oh, your Vanco level was only 7. So now for the last 3 days, you've been getting a subtherapeutic level.
Right.
So then we have to call and say, oh, now make the change, increase the dose. So it's very hard to manage Vanco in the outpatient setting because there's just so many logistical issues. If they go to, a rehab, or they're on dialysis where you don't really need to worry about levels or that kind of stuff, then it's not much of an issue. But in the outpatient setting, it's just very challenging. And the problem is that once you get the dose right, it never really stays right. Then sometimes you kind of overshoot it. Now you're like, oh, now the dose is too high. So now let's kind of hold the dose for 2 days and then start. It's just like a logistical, nightmare to use Vanco in the outpatient setting. Dapto once a day, you're done. You get your dose. We know 600 is your 600 milligrams. You're getting 600 milligrams, and we don't have to really worry about too much else.
Another question. Let's say somebody comes in and gets cut from what I understand, if it's like a clean cut in the emergency room, they don't even need antibiotics. I guess there are a couple of papers on that. But let's say it's a dirty cut. They cut a couple of extensor tendons, and the ER doctor is going to send them out to see me 2 or 3 days. What antibiotic now would you recommend? Are we still with the cephalosporins or with the higher incidence of MRSA, or should we be giving them something different?
Yeah, I mean, I think that MRSA is always. I think it depends on what the nature of the cut is and what their history is. So, and what their risk factors are. So there's certain, if it's say like an athlete, right, frequent locker room exposure, obviously MRSA is something, is a big deal, or they go to a gym on a regular basis, right? If it's some, lady who, some grandmother who's, cuts herself on a can or something like that, probably, not as concerned. But I think, you definitely have to include it because there is a significant, the recent data has kind of suggested that about 30% of individuals are walking around colonized with MRSA.
Right.
So
would you give doxy for that?
So you probably would, truthfully, you would probably have to give some sort of combination therapy because the problem with doxy and Bactrim are they're not really good. They're not really good strep drugs. They're good staph drugs, but they're not really good strep drugs. And strep is also is an organism that you would have to be concerned about. So you may have to do something like, even though I'm not really a big fan of this, like Keflex and Doxy, or Keflex and Bactrim, or Augmentin and Bactrim, or something like that, and stuff. If
This is the one that you were telling me about that that was interesting. I thought that was a good one because it was a cephalosporin, but it had some MRSA coverage. It's probably crazy expensive, but
there's only one cephalosporin that has MRSA coverage, but that's intravenous.
What about Duracell?
Yeah, it doesn't have.
It doesn't have MRSA.
No. There's only one cephalosporin that has MRSA coverage. It's intravenous.
Okay.
So I mean, like Zyvox would be, a good option if the patient can get it. Sometimes Zyvox, I would say 5 years ago was a little bit more challenging because of the cost of it, but it's since has gone generic, so it's a lot easier to get.
Okay.
So, but you just have to make sure, that they're not on any antipsychotic or antidepressants, et cetera, because of that potential reaction.
And that's for a dirty one in the ER. Like sometimes they'll ask us what we want them to send them out. So Zyvox would be.
Yeah, it's not unreasonable.
No, they're not.
You mentioned earlier for like joint infections, 6 weeks IV and then 3 months PO. Is that standard now?
So the guidelines are depending on what the hip is, or where the prosthesis is. So it's 6 weeks and 3 months for hips and 6 weeks and 6 months for knees.
6 weeks and 3 months for hip.
Correct.
That's even if you take the prosthesis out?
No, this is with retained prosthesis. Okay. Yeah.
But if you pull it out, then you're just doing the 6 weeks.
Yeah, because then what we do is we do 6 weeks, and then we give them a little time off, make sure everything looks okay, and then reimplant them accordingly. But if the prosthesis is maintained, then we do 6 weeks IV therapy with rifampin if can be utilized, and then either 3 months if it's hips, so oral plus rifampin for 3 months, or 6 months of oral therapy for knees.
And are you using these mid-cats now more commonly for the 6 weeks of IV antibiotics?
Oh, like midlines?
Yeah.
Yeah. I mean, they're pretty much less invasive than PICC lines and stuff. So I mean, theoretically, you're only supposed to keep them in for 4 weeks, but we've kept them in for longer and haven't really had any issues and stuff.
What are your recommendations for open fractures? Is there any standard still for if you're treating an open ankle fracture, the patient's admitted? Is there a recommended antibiotic treatment or anti-gen or?
I mean, we typically don't use, like when I talk to one of the other institutions I'm at, there's orthopedic residents, so we kind of have this discussion, and I know that's what the literature says. We don't really use a lot of gent and stuff because number one, gent doesn't really have great bone penetration. Number two is that the risk of toxicity with aminoglycosides is just very high. The kidney failure and that kind of stuff. And there's other drugs that give similar coverage to gen without all the side effects. So I would say something like anti-pseudomonal cephalosporin or something like that would probably be what I would use rather than using gent. And so yeah, we've kind of, unless we really have no other options, we really kind of shy away from using aminoglycosides because.
Which cephalosporin would you recommend?
So here, ceftazidime, Fortaz, that's an anti-pseudomonal.
For how long would you do?
I'm not really sure what the data on that is, so I would have to kind of look at that to give you a real answer. Okay. All right.
Thank you.
You're quite welcome.